Good afternoon. Thank you for attending this month's OCHAN Grand Rounds. I am your host, William Pinnock, and today, in honor of Cervical Health Awareness Month, I could not be more excited to have Dr. Patricia Carney of Oregon Health and Science University here to present Partnering with Rural Primary Care Clinics and Local Communities to Eliminate Disparities in HPV Vaccination. Dr. Patricia Carney has been a principal investigator, co-principal, or co-investigator of 31 observational or interventional studies and has had continuous NIH support for more than 25 years to study cancer control and health disparities, especially in underserved community-based settings. She also has training in educational psychology and expertise in educational intervention research for physician and patient behavior change, using physician and practice-based research networks, and medical education for American Indian Alaska Native students. She has mentored many medical students, graduate students, postdoctoral fellows, and junior faculty in the development of their research careers. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Patricia Carney for Partnering with Rural Primary Care Clinics and Local Communities to Eliminate Disparities in HPV Vaccination. Dr. Carney, the mic and the screen are yours.
Yay. Thank you so very much, William. Let me get my slides up and here we go. Again, if you have any questions at all, just put them in the chat and we can get to them because there's quite a bit of data here. And I want to do a big shout out to the OCHAN clinics that are part of this study because I know there are several of you. And I also want to do a huge shout out to my colleague, Bridget Hatch, whose picture is here. She's an assistant professor at OHSU. She is a co-investigator, and we are working diligently on our next round of funding, which we'll talk about toward the end. But Bridget has been an amazing colleague, and hopefully you'll see much more of her. Okay, so for today, I'm going to be talking about the current urban-rural disparities in HPV and how they are impacting health. Talk about strategies that the rural clinics with high HPV vaccination rates, that's our aim, one of our study, what we have learned about what they are doing to make this happen in their sites. I'm also going to describe the contributions of both a study we did on patient and clinic level factors on HPV vaccine. That's an effort that Bridget led. And then we have some validation study plans, and the Bridges Center is helping support some of those activities. And as everybody wants to know in this day and age, how is COVID affecting your study and what on earth are you going to do about that? So we'll chat about that as well. So just to provide a little background, unbelievable. This is just so unbelievable to me, but there are 14 million new cases of HPV diagnosed annually in the US, 14 million per year. More than half of these occur in folks who are 15 to 24 years of age. And starting in 2019, oropharyngeal cancer is now the most common cancer attributed to HPV. It most commonly occurs in males. And so HPV is now estimated to cause 70% of oropharyngeal cancers. And they are devastating diseases to receive treatment for, I should say. So even though the vaccine's been available since 2006, the vaccination rates really fall short, which is for 2030, 80% completion by age 13 to 15, and we are nowhere near that yet. So in 2020, 7.1% of adolescents in this age group had at least one dose of the vaccine, but only 58.6% actually completed the series. It is now a 2-dose series, though some folks who started with the 3-dose series are still receiving that type of vaccine. A lot of the reasons for the lack of initiation and completion, they're very multifactorial. There are patient issues, provider issues, clinic, community factors, and we'll talk about some of the ones that we have found in our study. And importantly, the rural clinics are way behind the urban clinics. So here's a study on vaccine completion in 2019, where rural boys were 0.63 odds ratios of being up to date with their HPV vaccine compared to urban boys, and rural girls were 0.74 odds ratios relative to urban girls. And you can see that the confidence intervals are below 1, so they're statistically significantly lower for rural children and young adults relative to urban folks. So we wrote a grant to the end. We got an award from the American Cancer Society. We started July 1st, 2018, and our funding ends on 2023. Myself and LJ Fagnan are the co-principal investigators, and our target population is both sexes, boys and girls aged 11 to 17 as part of the study. So here's our team, and I got to call out a couple things. One of the coolest things about this project is our partnership with the Oregon Immunization Program. And those are the folks who are circled in red. They have been just an amazing team of folks to work with. And then we also have Paul Darden, who's a pediatrician. There's Bridget, who's a family doctor. That's Michelle Berlin, who's an OBGYN. And then LJ, who's in family medicine. We have a mixture of qualitative and quantitative researchers on the team. And we are just having a boatload of fun, even though it's been challenging in some ways. So here are our 4 aims. It's mixed methods, baseline assessment of 12 clinics. And we wanted to look at both high performing and low performing. Then for aim 2, conduct a step-wedge cluster randomized trial of its practice facilitation or coaching intervention that has a couple of other components that we'll talk about at primary care clinics. So we have 5 groups or waves, and I'll show you what that looks like in terms of the study design. And then our third aim is to create this facilitated partnerships between primary care clinics and community organizations that the clinics identify. And the idea behind aim 3 is to create vaccine-ready families by having community groups and the primary care clinics working together. And our last aim is to develop a toolkit of best practices for clinics and state public health programs and the accountable care organizations. So those are our 4 aims. This is what our study design and timeline looks like. So we had an observational period where we conducted aim 1 to really understand in depth what high-performing clinics look like, and what they were doing relative to low-performing clinics. So that's aim 1. Aims 2 and 3 is our step-wedge randomized design. So everybody has a control period except group 1, the wave 1. And then they're staggered in terms of intervention. And then there's a follow-up period where we collect data on vaccine initiation and completion. And we're also looking at co-administration with Tdap, because that, if you get Tdap and you don't get HPV, it's a missed opportunity for vaccination. And then we have our data analysis and write-up, and then our toolkit development and dissemination. So the intervention components, it's a clinic-based intervention, and each clinic has an HPV vaccine champion. We use alert IS data as a quality review and for process metrics. So we show them where they are relative to other practices and in the entire state. And then the alert IS data is the state immunization bidirectional data exchange of vaccine delivery. So the Oregon Immunization Program maintains this database, and it is the data set we're using for our outcome measures. And then they have practice facilitation using coaching to establish a QI process. And that was effective in a prior study that Oropharyngeal did called Healthy Hearts Northwest. So how the PDSA cycles work is that each practice creates an aim statement. Here's an example of one: to increase completion of HPV series from 17.8 to 22.5% by June 30th. And also in 11 and 12-year-old patients. So in PDSA cycle number 1, They implemented a process for doing patient callbacks. They scrubbed the charts to see which patients had at least one dose. The front desk person makes 10 calls per week, and then they track the patients who come in for their second dose. And then for PDSA cycle number 2, they update the gap list that they initially used. And then they look at any inactivations in the alert system where that patient may have gone somewhere else for their second vaccine, a different doctor's office. And they conduct callbacks based on up-to-date gap lists. So that's the second intervention. And the third one is this community-based partnership between a clinic and somebody in the community. They get to pick whoever they want, and they have picked libraries, schools, dental clinics, public health offices. So this has been really fun to see. And what we did was we provided HPV materials and guidance along with $2,000 to support the community partnership. They worked together for about 12 months. And then to find out how this partnership is working, we use a point of care parent survey to assess the activity of a social marketing campaign on the parents, if they were more likely as a result of this campaign to talk about HPV with their children's physicians. And again, the whole idea is to create vaccine-ready families. So some of the examples of the partnerships, this is very diverse. So the libraries implemented a talk with the doc, and the docs from the practice would come to the libraries and do a presentation about HPV epidemiology, cancer epidemiology, and the vaccine. And they also gave out bookmarks, and you can see a couple of examples for the bookmarks there. One county health department used their money to create a sign that would be on the buses in the community, and that's what they decided to do. We had a dental clinic that did this great project, Take a Shot at Cancer, and the dentists would talk with parents about, because the kids are there every 6 months for the dental visits. So this makes, actually, we have an idea about a study to do with this. We'll talk about that in the toward the end of the session. And then also integral use services, like we provided flyers through this services. And so there was just a boatload of different things that the practices wanted to do. One of the other cool ones was Oregon Pacific Area Health Education Center, which is the AHEC. They had a HPV week where they pledged, they made shirts for all the staff, they had banners, they had raffle tickets, and they sold many raffle tickets, but again, it's this Take a Shot at Cancer theme. A middle school and a high school clinic staff went to the health class and shared educational materials about HPV and cancer prevention. The next door out in Hood River worked with their local clinic and underserved populations to create, this is a organization that works with Hispanic families. A lot of them are agricultural workers. So they translated everything into Spanish to provide information about the vaccine and what it can do to prevent cancers. So we've had some challenges, especially with COVID, but some of the things we've learned about the partnership is that aligning the partner and the clinic values and beliefs, especially when there was a lot of religious-oriented clinics or partners, you have to make sure you can carefully align those. There were community partners who didn't want to be associated as an organization with vaccines, and that got worse as a result of COVID. There wasn't enough of a capacity for clinics to create a partnership. It's kind of not in their job duties and assignments. It takes time. It's a hard time to find the time to do this. And of course, that was exacerbated with COVID. The schools only wanted to find partnerships that would affect their patient population. And they had a hard time partnering for a full 12 months. So they could do a project, but they couldn't do ongoing 12-month projects, even with a little bit of financial support. So we have many study measures. We have observational data that the practice facilitators are using for both intervention uptake and the toolkit development. Again, we get alert data from Oregon Immunization Program that comes to us quarterly, so we can see what the immunization rates are both across the entire state of Oregon, as well as with our study clinics. We have the point of care parent survey. So how that went was when parents or children had an appointment with their primary care doc, we would send them a survey within 48 hours of the visit that asked what they talked about during the visit, what the visit was for. Was it acute? Was it wellness? Was it illness? What kind of visit it was? And it's a very brief survey, but it provides a lot of really useful information. And then for our community partnership, we have both surveys and interviews, exit interviews that we do with the community partners. So for AIM-1, the green counties are where our AIM-1 participants were located. And after conducting the review of their vaccination data, we had 4 low performers and 8 high performers. And so the practice facilitators visited those clinics, and I'll show you what they found in a minute, to see what those high performing clinics were doing relative to the low performing. And then this is a map of all the AIM 2 and 3 participants. So you can see they're all over the state of Oregon, including some very rural areas as well. And so these were our AIM-1 findings. So in this AIM, we used a positive deviance framework to identify rural clinics with high versus lower vaccinations. We derived this, and you can see what the vaccination rates. So the high performers were people who, like, this is 70% of HPV being up to date among 13 to 17-year-olds. And it goes from 70% in the high performing group to 50%. And then you can see here, this is where the county level data turns, and the clinics are doing worse than county level data. So those we considered our low performing clinics, and these who were higher than the county level data we considered being the higher performing clinics. And you can see which of them were pediatric practices and which were family medicine. So we looked at what kinds of strategies the clinics used to vaccinate their children. And this is a very dense document, but I wanted just to show, we published this paper, and what you're looking at shows the kinds of strategies people do. So identifying patients do a common practice at these practices here. The first 8 are the high performing practices. And you can see the last 4 are the low performing practices, and they're not really implementing any kind of strategy. So for instance, immunization records systematically checked ahead of the visit to see what's due. Immunizations are administered at every visit if they're due, not just for like school visits or sports visits. And then they had in place some kind of reminder system. It was introduced, HPV was introduced as part, in a systematic way, as part of the vaccine series the child was due for. And then the presence of the vaccine champion was actually also really big. So the thematic results is that the staffing and vaccine protocols were important, and it involved some kind of standardized monitoring with staff and the use of bidirectional data so you could see exactly where the practice was. The vaccine champion that monitored inventory and provided feedback and advocacy, utilizing all opportunities to vaccinate, well visits, acute visits, same day visits, walk-in, and then communicating well with patients was another, especially with evidence-based messaging, and having the providers also deliver quite strong recommendations. So AIMS 2, 3, and 4 are still cooking, but in the meantime, we have been working on all sorts of fun things that I wanted to show you about. So I am going to come back to the interim analysis and how COVID looks like a bit later. So hang on to your seats for that, because it's very interesting. But a couple of other things we decided to do is conduct a pre-COVID analysis of clinic level HPV vaccine delivery. And I got to tell you, the OIP data are a gold mine. But of course, you guys already know what data gold mines are like because you're in Ocean, and you guys probably have the best gold mine on the planet. But anyway, in this study, for the background or rationale for this is most HPV vaccine studies are conducted at the patient or population level. there's very limited data that looks at the clinic level. And so we decided to use the Oregon Immunization Registry to look at differences in clinic level vaccination rates in rural and urban settings to really look specifically of how rurality is associated with initiation and completion rates, and then also look at clinical individual patient rurality and how they're associated with HPV initiation and completion. So this is a cross-sectional data set from 2019, before the year before COVID hit. And we had a population of family medicine and pediatric clinics in Oregon, and they were serving at least 50 patients who were in the age group 11 to 17. And they were participating in vaccine for children. So we had 539 clinics in this analysis. And we looked for dependent variables at the initiation rate for 11 to 12-year-olds, the completion rate for 13 to 17-year-olds. And then we looked at the HPV Tdap co-administration rates for the 11 to 17-year-olds, a whole age group. And we looked for independent variables at clinical level rurality defined by the zip codes. And we used the RUCA codes to categorize them as either urban and rural. And I'll show you what that looks like. And we used weighted clinic level data from the Oregon Vaccine Registry to conduct the data. So we had urban focused and rural focused using the RUCA codes. And the rural focused were large rural city or town focused, small rural town focused, or isolated small rural town focused. And we collapsed those three categories into the one rural focused. And we use weighted multivariable linear regression. And here's our findings from the patient and clinic characteristics. So the first one is the percent that are vaccine for children, both the mean and then we had the N. And so what you can see here is that there are more children in rural clinics, statistically more, that are in the Vaccine for Children program. They also are less likely to be children of color. And in terms of clinic type, they're much less likely to be in private practice, much more likely to be health department, community health center, and then of course the Indian Health Services. And for pediatricians, there are slight differences there. And then the number of youth, the urban practices had much higher populations of youth that are greater than 1,000. So you might imagine that they have different processes in place with a population that high in the urban setting. So this is what we found for unadjusted and adjusted HPV vaccination rates with our stratification according to rural urban. In the unadjusted analysis, you see a statistically significant difference between the two, where the initiation rates are about 51% in urban settings and 46.9% in rural. And then the completion rates for the 13 to 17-year-olds are 49.9 compared to 40.5. And those are all statistically significantly different. But when you adjust the HPV vaccination rates, those differences actually end up going away. And so that's an important novel finding from this research. And here's another way to look at it. So this is the first line is the unadjusted analysis, and the dotted line is the HPV 17 to 18-year-old HPV and Tdap. The light gray line, which is hard to read, is actually the 11 to 12 any HPV. So that's like the first dose. And then this other darker line is the 13 to 17-year-olds. So in the unadjusted, you can see how much variability there is in these three rates, especially for totally being up to date. When you adjust for patient characteristics, they start to align a bit closer together. When you adjust for the clinic characteristics, they especially the HPV Tdap co-administration and then receipt of any vaccine, they end up aligning really well. And then in the fully adjusted model, this is about as good as you can get. So it's still lower for completion, but it's very interesting to look at how these differences after adjustment alter the findings. So interpreting that, we found that rural and urban primary care clinics serving Oregon youth are very different. They have fewer youth of color. They are more likely to be Indian Health Service and public health department clinics. They serve more youth with Medicaid in rural areas. They're less likely to have youth initiate and complete HPV vaccines. But when adjusting for differences in patient and clinic factors, the differences are no longer significant between the two. But both clinic and patient factors account for some of the rural-urban differences. So this paper is now in review at the Annals of Family Medicine, fingers crossed. And then the other big thing that is important to us, especially if we're going to continue to do future work in this area, is validating the use of state immunization data to study HPV vaccination rates. So when we wrote the grant, the Oregon Immunization Program, they had only validated its registry for Tdap. And so that's for like little young kids relative to teenagers, which we all know can be challenging for getting stuff like this done. And so the state-based immunization systems, that what they do is they consolidate all their vaccine doses administered by participating providers to patients residing within a given geopolitical area. The range and use of registries varies all over the country, right? There's some parts of the country, like Washington State is 96%, but in New Hampshire, it's only 16%. So there's a lot of variability out there. And this issue has been studied a little bit. So Madewell did a study in 2017 and their colleagues. And what these folks found is that there's moderate agreement between a telephone survey of vaccine receipt and then the Alert IS system for diphtheria and tetanus and pertussis. So the agreement there was 0.49, which is just moderate. K is for Kappa, and it's a funny statistic. But so someone said, well, 0.49 isn't that high, but for a Kappa, it's considered moderate. For pneumococcal, it was 0.49 as well. Influenza, it was 0.46. They found fair agreement for varicella, polio, measles, mumps, and rubella, and that ranged from 0.35 to 0.39. And then slight agreement for hepatitis B, which was 0.17, but they did not include HPV in their study. Hendricks did, but it was batched. So Hendrickson, he compared the completeness of the Arizona immunization system. He compared it to electronic health records at a large community health provider using the Arizona exchange data with the Arizona system. And then they also compared personal immunization records. And what they found, so they looked at the completeness of all these three sources, and the state registry was found to be about 71.8% complete. The hospital electronic health record was about 81.9%. Personal records, I was surprised by this, 87.8% complete, which was the highest. Of the 2017 unique vaccination administrations, 65 were present in all three sources, 24.6 in two of the three, and 10.4 in just one source. But only 11% of patients had records with complete agreement across all three sources. So the HPV was included, but it was batched with other vaccines. So it was hard to tease out exactly what was going on with the HPV vaccine. So we decided we have got to study this. So our plan is to get data from the AIM-1 and some of the AIM-2 rave practices participating in the OIP. We're going to look at HPV shots 1 and 2 or 1, 2, and 3 for all age-appropriate boys and girls. And we're going to assess cases where both sources have complete data and the extent to which one has more or less than the other data source. So we're going to look at things like whether the hospital is health system or hospital owned, privately owned, publicly owned, the size of the clinic, and look at where it's complete. We're going to look at the age groups of the children as well as the sex of the children. And then we're hoping to understand overall completeness, and we're hoping it's going to be greater than 90%. So that's definitely an area that we care very much about validating. And so now the impact of COVID on what we've been doing. And in terms of implementing and facilitating change at the practices, we had to move to all virtual meeting mode. And we had to be incredibly flexible and much less prescriptive with our project work. The quality improvement emphasis depended on the practice's capacity to actually engage with us. And that was really, really variable. Some folks were so distracted with the COVID care issues and school closures and hospital closure, not hospital closures, but a lot of the clinics were seeing patients in the parking lot instead of having them in. So this was just incredibly disruptive. And we just decided a lot of states did different things. A lot of universities did different things. So for example, Paul Darden, who is our pediatrician co-investigator, he's from Oklahoma, and the University of Oklahoma actually decided to suspend every study that included human subjects during the COVID vaccine, during the COVID pandemic. And our IRB, our institution, did not do that. What we decided to do was, if practices wanted to pause, they could choose to pause. And we just would engage with them if they wanted to, and not if they didn't want to. And some folks were actually quite keen on doing something other than COVID. And I was surprised at the number that actually did want to stay engaged in this work, which of course has some relationship to vaccinations related to COVID. So in terms of AIM 3 and the community connections, the types of activities had to be safe. So there were no more in-person activities like our visits with the schools that had to end. It was much harder as a result of COVID to even solidify a plan with any school about what we might do. And then there were priorities for things like adolescent immunization, and the CCO incentive metric was not threshold-based meeting, not needed this year. So those kinds of CCO metric incentives ended up changing, which affected the priorities that the practices had, because it was financially related. And then there were practice staffing shortages that got quite chaotic. And then their capacity to do something other than care for patients with COVID or COVID-related illnesses ended up being a huge impact. So here's our average facilitation times by month. This has occurred in 2020 when you can see that we were quite active with them in January and February. But when COVID hit in March, things really, really dropped. They started picking up a bit in June, and then, not surprising, also started dropping off again, as they often do in the summertime. And they have dropped off again, even now. The other part is the relationships. Really fostering or continuing to foster those facilitator relationships was huge. So the facilitators were kind of a clearinghouse of information, letting us know exactly what was happening with the practices and their readiness to engage. The stakeholders, especially the Oregon Immunization Program, you can imagine what they were going through during the pandemic. And so we had to do what we could to be huge champions for them and for every single practice in the study. So you're probably wondering what this photo is. So we decided to buy boxes of chocolate for every practice that was in the study. We sent along an encouraging thank you note for hanging in, providing care for your patients during this very difficult pandemic, and for being in the RAVE Oropharyngeal study. And so they really appreciated just the small acknowledgement of their contributions to their communities and to research. So our own team priorities changed. We have been having less meetings. We don't have them face-to-face anymore. They're still going virtual. We've done a lot of outreach with newsletters, a letter from the PI, and just sort of acknowledging the uncertainties of COVID. So we did start looking at our interim analyses, and this is this is what it looked like currently with the initiated and up to date. The control practices are those not in RAVE, the intervention practices are. So you can see the differences between the initiation and the up to date in the two age groups. And there's some difference here. This is data from 2019 to 2020, so it is affected by the COVID pandemic. But you can see that time absolutely does matter. So COVID hit about here, and what you're looking at here is the HPV mean vaccination percentage. This is 1 or 2 doses, and then this is the 1, 2, or 3, depending, excludes those who are overdue, but this is up to date folks. And the two age groups, the 11 to 12-year-olds are the red line, and then the kind of teal line are the 13 to 17-year-olds. And then here's in the kind of second quarter is when COVID hit. And so you see kind of this pretty steady line, but then it's starting to drop, both for initiation and then, of course, completion, especially in the younger age group. So it's a lot of data to look at, but you can see that the initiation is at about 63% for the 13 to 17-year-olds and about 40% for the 11 to 12-year-olds. And then, that's pretty steady. And then you can see it start to drop, especially in the 11 to 12-year-old initiation and with completion. You can see it dropping, especially in those 11 and 12-year-olds. So this is according to our WAVE, and this is initiation of the vaccine from 11 to 12-year-olds. And so WAVE 1 is this one here, and what you can see is that every practice who was randomized to WAVE 1, and this is again where the red line is when COVID kind of hit, everything sort of started decreasing after that. And our control group, which is all the practices who aren't in RAVE, are this gray line that I'm pointing to here. That's a control group. But you can see that even though the clinics were randomized to their WAVE, there is this clustering effect that we're quite it's not explained by the Hawthorne effect, right? That because even the control group has this very similar increase in this pre-period, and they didn't even know about RAVE. So this is quite interesting to us. And anyway, the WAVE 1 is the group that got the intervention first, which is what that wraparound looks like. And for example, WAVE 4 is getting the intervention now, and WAVE 3 has had this intervention during this point in time, and this is WAVE 2. So yeah, we have a lot of work to do to try to understand these data. One of the things that our biostatistician is quite confident about is that we'll be able to use some of the pre-2020 data to figure out what the impact of the intervention is, and then do some modeling to show what we would have expected to happen if COVID didn't occur. So that's definitely on our plan for some of the next things we'll be doing. And here's the interim analysis, also according to the WAVES and according to the intervention and control groups. So this is initiation, and this is completion. And you see very similar things where when COVID hit, there was much more variability in what folks were able to do. So we've got many future grants and papers that we want to be working on. I'm very excited about this. So we have convened a group that's going to be conducting a clinical trial for the interface between primary care and pharmacy HPV vaccine partnerships. And we want to study the delivery of the first dose at the primary care clinic and then referral to the pharmacy for the second dose. We're trying to decide whether we want to do an R34 or an R01. R34 is the clinical trial prep, but the money's not very big. So I suspect we're going to do our best to go for the R01. And then our second idea is to look at an R21 for a partnership between primary care and dentistry. And one of the things that I just recently saw a webinar with an Oregon dentist who's a very big fan of the HPV vaccine. And his practice at his office is when the kids come in, they ask the parents about the HPV vaccine. And if they haven't initiated or completed it, they have the receptionist call the primary care doc's office and schedule it. That's what he does in his office. I think that's amazing. So we have many papers that we're working on. AIM-1 paper has already been published in the American Journal of Preventive Medicine. We did a scoping literature review on primary care and pharmacy HPV vaccine partnerships. We looked at 508 papers, only 17 of them met criteria. They were all very small studies with no control groups. So that was the initiative for us to start thinking about the R01. We'll have a main effects paper on the impact of the interventions, both the clinic-based intervention and then the effects that the partnership has. And then we have a parent survey paper planned. We have an impact of COVID paper planned, and I wish we could get that finished. And then we have COVID co-administration study, like what vaccines are being given with COVID co-administration. And then lastly, the effects of COVID on receipt of childhood vaccines, which is a medical student project. So we are doing quite a bit with this project and are having a boatload of fun doing it. What I really care about is RAVE's ripple effects, that it starts with a study like this. We have our participating clinics, we have our partners, we have the greater health community. This is just the kind of thing that we want to be doing in this kind of research. So that's my last slide. I want to thank you all for your attention.
Well, thank you, Dr. Carney, for that fantastic presentation. And thank you to everyone who attended today's session. Be sure to keep up to date with ORPRN activities at ohsu.edu/Oregon-rural-practice-based-research-network. And be sure to follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to ochin.org and advancedcollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to check out our OCHIN YouTube channel to catch up on our past Grand Round presentations. And stay tuned for next month's OCHIN Grand Rounds as we welcome Dr. Blair Darney of Oregon Health and Science University to present on contraceptive services in community health center settings. Invitations to this event will be sent 2 weeks prior, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, at ochin.org. So from all of us at OCHIN to all of you, have a wonderful rest of your day and stay healthy out there.